Okay, good morning, good afternoon, everyone. We are sitting right at 12 noon here in Ontario. I think maybe, I still see some participants sort of like coming on in really quick succession. So I think I'll give it another minute, minute and a half, and then we will get started. Thank you so much for joining us. Okay, awesome. I think we have a good critical mass, so let's get started. Hello, good afternoon, good morning, everyone. My name is Nicole Bodner. I am the communications lead for the Canadian Partnership for Tomorrow project. Thank you and welcome, and thank you for joining today's webinar, spanning bench to behavior, harnessing CPTP data to understand lifestyle risks across the health spectrum. We are very pleased to host this second webinar under the University of Toronto as CPTP's National Coordinating Centre, and we're hosting this in partnership today with Alberta's Tomorrow project. Before we introduce our speaker, I have just a few housekeeping items. So number one, we'll have lots of time for questions following today's presentation. I ask you please, to ask a question, please use the Q&A button at the bottom of the Zoom window, and you can type in your question here. Jennifer will read the question and then deliver her answer at the end. If we can't get to all of the questions, please do reach out to us by email, and we'll be happy to connect with you anytime. Our email is info@partnershipfortomorrow.ca. And finally, all the slides from today's presentation will be available in both English and French on the CPTP website following this webinar. So with that, I'd now like to invite my colleague, Sharon Basarabra, to introduce our keynote speaker. Sharon is the Senior Advisor of Scientific Communications and Engagement within Cancer Control at Alberta Health Services. Sharon.
Thanks, Nicole. I'm very happy to introduce our presenter today. Dr. Jennifer Vena is the Scientific Director of Alberta's Tomorrow Project, which is a founding member of the National Consortium, the Canadian Partnership for Tomorrow Project. ATP, as we're known, has been collecting data from our 55,000 participants dating back to the project's launch in the year 2000. It's the largest health study in the province's history. Dr. Vena is a homegrown Alberta scientist. She conducted her training at the University of Calgary and the University of Alberta. She's done postdoctoral work in Texas and back here in Alberta, specializing in the areas of metabolic disorders and nutrition. For Jennifer, though, food is not just a professional focus, it's personal. You can tell by her Twitter handle, which is @foodmotivated. But enough about her personal lifestyle. I'm delighted now to turn it over to Jennifer.
Thanks so much, Sharon. Thank you to everybody who's joined the webinar today. Really excited to talk to you today about the importance of lifestyle behaviors and how CPTP data is being used across the health spectrum, not just for prevention, but beyond. I'd also like to extend a welcome to any participants that we have on the webinar today. Very happy to have you here and very grateful for your continued participation and support in the project. So as Sharon mentioned, my background is in nutrition and really lifestyle behaviors. And we do think about it in terms of prevention, but the nice thing about lifestyle behaviors is that if you are targeting them for prevention of one disease, you're also going to influence your risk for other types of diseases. So in terms of bang for your buck, it's pretty good value. And when we think about it from an exposure perspective, again, my background is in food, and that is where my passion lies. But in terms of an exposure, your diet and the food that you eat is something that you're exposed to multiple times a day, every day. So it really is important for determining health. So I'm going to focus on cancer, but the most recent third expert report from the World Cancer Research Foundation and the American Institute for Cancer Research was released in 2018. So these expert reports are a huge amount of work. They are released roughly every 7 to 10 years, and they really evaluate the evidence to date in order to put forward recommendations for how people can reduce their risk for cancer. So again, this is a huge undertaking. They review thousands of studies in detail to try to come up with the recommendations that at least have strong enough evidence that they can be quite confident in recommending them. So the third expert report, the most recent one, came out in 2018, and the recommendations are to be a healthy weight, be physically active, eat whole grains, vegetables, fruit, and beans, limit fast foods, limit red and processed meat, limit sugar, sweetened beverages, and alcohol consumptions, and don't rely on supplements. That last one is really just a focus more on trying to obtain all your needed nutrients from food instead of taking supplements. And obviously this isn't going to apply across every case, but again, it's meant as very general population level recommendations. This is complemented by a suite of other recommendations, including avoiding tobacco exposure, direct and indirect, as well as excess sun exposure, and specific chronic infections, which have been shown to be highly linked to certain cancers. So these recommendations are put forth and are really meant to work together. They're not really meant to be piecemealed into, well, I'm following one, so I don't really have to follow the rest. They're really meant to work in concert together and have synergistic effects to really maximize your risk reduction. And in terms of whether these recommendations work or not, is an active area of study. So you might have seen the COMPARE study, which recently was released. That was also a great deal of work. It was a national level study, and it was really trying to estimate how many cancer cases could be prevented in Canada if certain lifestyle behaviors were targeted to meet current guidelines. And so I'm not going to spend a lot of time going over this slide. They have a fantastic website, which is at the bottom there, prevent.cancer.ca. If you want to go in and play around, it has a lot of information and a lot of wonderful infographics and information about the specific exposures, how they determine the evidence, and for specific cancer types as well. So I just wanted to pause for a quick second and recognize the nuances between prevention and risk reduction. So we tend to use the term prevention a lot. And this is because ultimately we do want to prevent disease. It is a lot harder to reverse disease once it is set in. So we want, on a population level, we want to prevent as many cases of disease as we can. But more accurately, when we're talking about an individual, so now going from population to the individual, most people want to know how they can personally reduce their risk of disease as much as possible. And particularly when we talk about cancer, the reality is that we are unlikely to be able to prevent cancer entirely. But we can try and reduce the risk as much as possible and also focus on things like early detection and treatments. But it is, we can't really say with confidence, if you do all these things, you're not going to get cancer. That's just not a reality. And in fact, we all know somebody who looks very good on paper, meaning they're following the recommendations, but unfortunately they still get cancer. So obviously there's a lot more to understand, but that is a little bit of a nuance. And because there are participants on the webinar today, I do want to highlight that because that has something that has been communicated with us as being a really important distinction. So again, the goal of the recommendations, even though they're called cancer prevention guidelines, they really are meant to try to help people make healthy choices to reduce their risk. So the guidelines came out and they're, they can be confident in these findings for a general sort of population level risk, but they still also highlighted some gaps in the evidence and where further research really is still needed, which I'll highlight in a few slides. But one of the things is, so with all this evidence, why can we still not totally understand what influences why one person gets sick and one person doesn't? And that's really because understanding risk is complex. And so this is a very simple graphic. I did make it myself. Don't worry, I have many other talents that do not include graphic design. But it's really just meant to capture all of the different types of factors and exposures that really influence your personal risk for staying healthy or potentially developing a condition or disease. And really it's just that understanding exposures is complex because life is complex. So you have your individual factors, which at the core will be your genetics, which are estimated to contribute or determine about 30% of your risk for disease, but that leaves 70% for sort of the external environment. Your genetics will determine potentially how you respond to treatment or how you respond to things like dietary interventions or air pollution or stress. So they do play an important role. But really that leaves also the external environment, which can also include things like lifestyle choices, which I have deliberately put in quotations. And that's because we think of them as individual decisions in terms of what we eat, how active we are, how much sleep we get. But when you actually think about the decisions that you make around these things, they're actually not very simple at all. They are usually influenced by other factors, both within and outside of your control. So I like to think about it as trying to make a healthy choice in an airport, and not one of the nice European airports where you can get fresh sandwiches and fresh squeezed orange juice and the produce is, well, you can get produce and it's fresh and lovely. I think about it, in some of the Canadian airports, especially if you're in the terminal with basically just Pizza Hut or something like that. And so in that situation, even if I have the knowledge to as to what a healthy food choice would be, and even if I have the money to be able to pay for it, the options may not be available to me. And so in that situation, I could intend to make the right choice, but that option might not be available to me. So just underscoring that there are lots of other complex factors, and typically we also think about trade-offs. So people are busy, they're working, and really I could prioritize sleep or I could prioritize exercise in the evenings. And that's going to be a trade-off because each is going to have an effect. So beyond lifestyle, we also have things like social factors, family history, which also is related to genetics, but also not. Things like your education and income and occupation, which we call socioeconomic factors, as well as the environment and also the health system. So with health system, that's more like access to services, which if you're in a big city, generally not as much of a problem, but if you're in a rural community, you might only have a physician that comes to your community once a month. So that's obviously going to determine how you are able to access services, even if you want to be proactive or seek quick treatment. So there's also a concept now of epigenetics, which is basically a modification of your genetics based on the exposures. So underscoring that even though you might have a set genetic code, there can be modifications made in how those genes function, which is influenced by lifestyle, air pollution, etc. So all of this to say that health risk actually is very complex, and it's the net effect of all these factors working together that is going to determine your personal level of risk. So when you think about it that way, actually trying to narrow down and determine the net effect of all these things is actually quite difficult. So the second point I wanted to make is what we typically think about lifestyle behaviors like diet, physical activity, smoking, alcohol, etc. as I mean, they're called prevention behaviors. And so we typically only think of them in terms of the beginning of this pathway where you have, a healthy state, and then at some point you might be diagnosed with a disease. And then after that, there's essentially three main pathways that you can follow. So you have a treatment or an intervention. This could be a lot of variety of things, but ideally you have recovery and return to health. In some cases, you might have disease management. So for example, if you're diagnosed with diabetes, a lot of energy then goes into managing the diabetes to ensure that you don't proceed to complications. And unfortunately, in some cases, you do have end-of-life care. But the point I want to make about lifestyle behaviors is they're not just important at this early stage between whether you get sick with something or not. There's really no point along this trajectory where they're not going to have some type of influence and may even play a role in which pathway you end up going down. The other thing I wanted to point out is that ideally for cancer, you will have recovery and return to health. As our treatments get better, we are seeing an increase in cancer survivors, which is fantastic. But one of the issues is that, the treatments and the interventions that we currently have are no joke. They tend to have more chronic lasting effects on the body and can have effects on bone, cardiovascular system, even cognition and brain health. So even though we think about the fact that, maybe the cancer is gone, it's likely that we still need to manage a number of other conditions on that road to recovery. And it's also likely that these individuals might have different needs than simply just what we think of for prevention. And so all of that needs to be teased out. So as I mentioned, the third expert report highlighted some areas where research is still needed. They identified 6 areas. I'm just going to focus on 4. So they did highlight the need to understand how diet and physical activity impact throughout the life, specifically for cancer risk, but honestly, you could apply this to any chronic disease. Really understanding both intentional and unintentional changes. So if you intentionally lose weight by making positive lifestyle changes, how does that then change your risk? Because typically we look at you in one point in time and we try to estimate what your risk is going to be, or try to look back and say, okay, you were doing this 10 years ago, X% of your disease risk now is due to that. But really you are changing over time. You're changing your behaviors and you're changing your physiology, your metabolic state. So we really need to understand that better. We also need to understand and collect better data, essentially. Like, these behaviors and these factors are complex and they can be difficult to measure accurately and precisely. So we need better quality data, and we need it over time to, again, understand how within the system, which is both yourself and the broader health system, how those changes influence risk. And finally, we need to explore more holistic approaches. So when it comes to food, we don't typically eat isolated nutrients. We eat foods. Those are meant to, foods act synergistically together, sometimes in opposition. They also work with other lifestyle behaviors like physical activity. So taking a more systems approach to understanding what the net effects are, because you as an individual are a system, and you are also within a broader health system. and exploring biomarkers so that we can understand what the metabolic effects of some of these behaviors are. So those really focus on this healthy to disease trajectory, which is your risk, but then also after disease and related to outcomes after having cancer. So better understanding how these lifestyle behaviors relate to specific types of cancers and responses to treatment, and how they influence non-cancer outcomes, such as cardiovascular disease, due to survival. And we also need to understand how the activities and behaviors interact with genetics and hormonal factors, all of those things that come after your sort of through dealing with the cancer itself. So these are big, big questions. And to answer these questions, you need to collect a wide variety of data. So again, taking that systems level approach for the individual and all of the exposures in their life. You also need to collect the data on a large number of people. So when we're talking about population, we tend to sort of average out what we see as the effect. But most people want to know, what is my individual risk? And for that, you come with a certain set of behaviors that is probably different than your neighbor or the person across the street. So in order to have enough numbers to be confident in what we are seeing and to be able to make recommendations, we need to start with a large number of people so that by the time we whittle it down to you or people that look like you, we have enough data really to be able to say, okay, this is the trend we're seeing across enough people that we can be confident to recommend this. And so this applies to both exposures, so say being vegan or vegetarian, or having a condition like inflammatory bowel disease, also to specific types of cancers, like pancreatic cancer, which unfortunately has a very high mortality rate. And finally, we need to follow these people over time to really understand how their behaviors at one time influences risk, but really how their behaviors change over time and how that modifies their risk. So this is where large-scale population health studies come in. They help to assess disease risk because we collect information from people over time. Unfortunately, some people develop disease, some will pass away, and some will remain healthy. And so the whole point is to try to understand what differentiates the people who develop something versus those who don't. So this is the whole premise of the Canadian Partnership for Tomorrow project, which is a longitudinal cohort study. We're not just a study, we really are a population health research platform. We want to be able to understand the net effect of genetics, behavior, family health, and environment on chronic disease. And so our website is cptp.ca if you want more information. And we also invite you to listen to the introductory webinar that our National Scientific Director, Philip, provided in June. It is on the website. So just briefly, the CPTP is essentially a consortium of 6 different cohorts across 9 provinces, and we have 320,000 participants enrolled, and that is growing. So we have established cohorts in BC, Alberta, Ontario, Quebec, and the Atlantic provinces. Manitoba is in the midst of recruiting now, so if you are in Manitoba, I encourage you to reach out to them. They are aiming for 10,000 participants. And it has been estimated that 1 in every 100 Canadians is currently participating in the CPTP, which is fantastic. So we have collected health data, biological samples, physical measures, and intend to follow people over time, as well as obtain consent from participants for data linkage. And this really helps expand the database and capture those exposures that are, again, beyond the individual themselves. So the types of health and lifestyle data that we've collected include things like diet, which includes just fruits and vegetable intake, but there is more detailed dietary data in some of the cohorts, as well as body size, sleep, physical activity, smoking, family history, screening, occupation, sort of a wide variety of things. And this is actually really important because this type of data is not often captured in other databases such as your health records. So we can use administrative data to look at things like outcomes and use of the health system, but it's not going to have these important lifestyle factors, which are very strong determinants of health. In terms of biosamples and physical measurements, the biosamples that we have available include plasma, serum, red blood cells, buffy coat, dried blood spots in some, urine and saliva, and we have toenails collected in the Atlantic Path cohort. And in case you were wondering, yes, they hold a Guinness World Record for the number of toenails collected. There is lab data available from these blood samples in some of the cohorts, and for physical measures, participants attended a study center or mobile unit where they had their blood drawn and the other samples provided, but also we measured their height, weight, waist circumference, body fat by bioelectrical impedance, grip strength, blood pressure, and resting heart rate. And so all of that is currently available for access. And finally, as I mentioned, we also obtained permission for data linkage. So primarily we do this through participants' personal information, like their healthcare numbers, date of birth, etc., which is kept under strict privacy and security regulations by the data custodians. It is never released to individual researchers, and it is only used for linkage purposes and then removed from any data that's sent out. But we also link based on postal code. So similar with postal code, we don't give out 6-digit postal codes because that's pretty specific to your neighborhood. But we will link with existing reference databases such as the CNU database, which is a fantastic resource that has a number of neighborhood and environmental data like air pollution, nighttime light, and walkability available on postal codes throughout Canada. So this provides a lot of really complementary information without having to burden participants with asking them for it, and really helps to fill out that picture of all of the exposures and all of the factors that influence health. So I just wanted to provide a really brief snapshot of who the CPTP participants are. This is all data from their enrollment questionnaires when they came into CPTP. And if you want more information, I encourage you to go to the paper by Trevor Dummer, who is the BC Generations Project co-scientific director and our national co-scientific director, published last year. And then each of the regional cohorts also have profile papers available. But we do have a majority of women, which is very typical for research studies. Distribution across the age range from 35 to over 65. And of course, those participants are aging now. And I was reminded to apologize for the, the physical decline that it looks like in the images there. I know not all 65-year-olds are walking with canes, so that's not the intention there. Approximately half of our participants have never smoked, and then about a third are former smokers, 13% current smokers. Roughly even distribution of BMI, actually not weight, but BMI. And so very similar risk of chronic conditions that you will see in the general population in terms of the most common risk factors, including blood pressure, diabetes, and arthritis. So again, the purpose of the seminar really is to highlight how CPTP data is being used to answer questions about cancer, both risk and across the spectrum. So I wanted to provide just a few examples to highlight, give you a flavor of what the data is, how it's being used. This is not an exhaustive list, so many more studies are being conducted, and I encourage you to go to the CPTP website and the cohort websites to look at the activities underway. I also apologize in advance. I am from Alberta, so I'm more familiar with the studies ongoing there. So you might see a bit of an Alberta slant, but that's not intentional. So the first one I wanted to highlight is being done by Rachel Murphy through a CIHR grant, and it's really looking at risk of lung cancer. Lung cancer is one of the most commonly diagnosed cancers still, and it has a quite high mortality, unfortunately. But not all people who develop or who smoke develop lung cancer. And on the flip side, up to a quarter of lung cancers happen in people who have never smoked. So obviously there must be other factors that play a role. And so this study is going to look at what we think of as the traditional risk factors for lung cancer, but also exploring through all of the other data collected by CPTP, what other factors may play a role in determining that risk. Dr. Darren Brenner, who's at the University of Calgary here and was on the COMPARE study, is interested in young onset breast cancer. So despite breast cancer diagnoses going down in older women recently, which is a lot of work through advocacy and screening and other efforts, the diagnoses in women under the age of 50 have increased. And this is actually really concerning because screening starts at 50. And so younger women are typically not routinely screened. And so by the time they present, they often have more advanced stage disease, which again is harder to intervene at that point. Genetics might play a role, but generally only account for 5 to 10%. So obviously, again, other things must be going on. And so he is looking at data from BC, Alberta, and Ontario. This might just have to do with the numbers of cases and the availability of the registry data to understand what other factors might be involved in young onset breast cancer. So I also highlighted from the third report that we need to better understand risk factors themselves. So better understand diet, physical activity, body weight, that kind of thing. So Dr. Vicky Ho is looking at occupational physical activity and lung cancer risk. So we know that physical activity can reduce risk of some cancers, but there's also different types of physical activity. Often in studies, we only consider leisure time physical activity, but there are also a lot of work-related or transportation-related physical activity that people undertake. So whereas recreational physical activity has been shown to reduce lung cancer risk, the impact of work or occupational activity is not well understood. And some studies have suggested that people who have physically demanding jobs have a higher risk of lung cancer. And whether that's due to other types of environmental exposures or things inherent to the work that they do is not totally understood. And so she's going to be teasing that apart. Vanessa Dickler. So this is actually a published study in Nutrients, and she was looking at the association between diet quality and adiposity or excess body fat in the Atlantic Path cohort. So the Atlantic region is quite interesting because life expectancy is lower and most chronic conditions are more common in the Atlantic region. There are differences as you go east to west across Canada. So even though we're all Canadian, there are very different risks, and you have to look more context specific. It's thought that poor diet is associated with chronic conditions, maybe mediated through obesity. So what they found was diet quality was actually different across the provinces. Overall, it was a bit concerning because participants reported consuming not enough fruits and vegetables, although they did have some healthy choices like eating whole grains more than refined grains and eating at fast food restaurants less than once per month. The measures of adiposity or excess body fat were also different across the provinces and were associated with food items which you would probably expect on the average. But really one of the interesting takeaways was that even though all 4 provinces are in the Atlantic region, and you might just say, okay, well, they're probably very similar. Diet quality actually was very different across the regions. And so if you are sitting on the policy side and you're thinking about how would I create an intervention, I think it underscores that you really do have to take a context-specific approach and see where are the issues in that particular region and how can we address them. And then the other one I wanted to point out, if you haven't seen a lot of the controversy about red and processed meat lately, this is a very timely study. So looking at red and processed meat, but in the context of the other elements of the diet. So evidence suggests that red and processed meat increases cancer risk. And then also there is a socioeconomic component. So socioeconomic status influences ability to follow a healthy diet, and that may in and of itself have an interaction with health risk as well. But again, taking a cue from the third expert report and sort of where the literature is heading, we can't just look at individual food items or nutrients in terms of their risk, because that's not typically how we behave. We consume foods in combinations and whole foods. So you really have to look at the diet as a whole to understand what the net effect is of red meat intake. And it might be, say, if you love red and processed meat, well, then maybe you have to hit a different threshold for fruits, vegetables, and fiber than somebody who doesn't eat a lot of meat. But we need to understand that better so we know how to better intervene and recommend to people how to reduce their risk. So Katerina is looking at the association of red meat with the other components of the diet, and also how socioeconomic status might influence that risk. Okay, so I also highlighted that CPTP data is being used to look at lifestyle factors across the disease spectrum. Sorry, we just have a bit of a freeze here. There we go. Winston Chung is a health systems researcher here at Alberta Health Services, and what he's really interested in is whether your healthy lifestyle habits influence your trajectory through cancer. So even if you get diagnosed with cancer, does it influence the way you respond to treatment, and does it prevent you from potentially getting another cancer down the road? So this is a really lovely project. It will also be presented at the Canadian Cancer Research Conference. It took data from Alberta's Tomorrow Project, along with the Cancer Registry for Cancer Outcomes, and ARIA-MO, which is the medical oncology, the treatment information. And I really like this quote from him, because he says, "We can't prevent all cancers, but it would be nice to be able to tell participants one day if they're still better off through treatment and beyond because of earlier health habits." And I think that's really important, because I think a lot of participants can do their best and really try within their control to make good choices, but ultimately they might still get cancer and feel a bit cheated. So I think it's a really lovely study that will hopefully show how lifestyle behaviors are important across that whole trajectory. The other one I wanted to highlight was Melanie Keats, who is with Athletic Path, and looking again at the relationship between cardiovascular disease and physical activity in cancer survivors. So following on the idea that cancer survivors, they beat cancer, but that doesn't mean that they don't have concerns about other health issues. So they found that cancer survivors were more likely to have some sort of cardiovascular event or risk factor, like high blood pressure, diabetes. But if they were moderately or highly physically active, they actually had a reduced risk of those CBD risk factors of about 35 to 45% if they were moderately to highly active, compared to survivors with the lowest physical activity. But I also thought it was interesting that for the non-cancer control, so people who were same age, same sex, but hadn't had cancer, their odds were lower 25 to 30%. So to me, that suggests that physical activity actually is even more important in cancer survivors, because they are likely to have an increased risk for cardiovascular complications, but it does show that it can be effective. So focus on physical activity in cancer survivors should be part of the recovery plan. Okay, so the last thing I wanted to highlight really is around the importance of external factors. So the third report highlights that although information or knowledge are important in influencing risk of disease, there's lots of other factors that are outside people's direct control. So if you recall the systems level diagram that I showed before, your level of control might only be yourself and your choices, quote unquote, but there's lots of other things that are actually influencing those. So we need to consider the environment within which people make their choices, because there's environmental, economic, and social factors that are all upstream determinants of behaviors and choices. And these can also lead to health inequalities, because lower socioeconomic groups are more likely to be affected by these sort of systems level determinants. So prevention has to be a cornerstone of a cancer control plan, but it can't just be health. It has to be include these broader determinants of health. So I just wanted to point out a couple examples where CPTP data is being used to try to look at some of these broader systems level factors. And one of them is Dr. Gavin McCormack, who is focused on the built environment. So things like the walkability of your neighborhood and how how supportive or not supportive it is to recreational transportation, physical activity. A lot of the evidence for the notion that built environment can help encourage physical activity levels is available from cross-sectional studies, which don't really tell you whether the neighborhood, the walkability of the neighborhood can increase physical activity or if it's just a coincidence. So they're doing a neat study in Alberta's Tomorrow project where they're looking at people who have moved from one neighborhood to another and looking at the walkability of those neighborhoods, the change in walkability, and whether that influenced their physical activity, specifically walking, between time 1 and time 2. So because we have participants' postal codes, they can estimate the walkability of the neighborhood and look at participants' physical activity that they reported in the old neighborhood and now in the new neighborhood and see whether or not that changed. So he typically frames it as a natural experiment, which I really like, because if you were actually going to do this as a controlled trial where you physically move people to different locations, that would obviously be very expensive and be very logistically challenging, whereas the cohort framework allows you to do this type of analysis without directly having to place people in different locations. And so this will be very informative for city planners and policymakers to understand how they can help create supportive neighborhoods. One other one I wanted to highlight was also done in Alberta's Tomorrow project by our own research team, and it was looking at the change in secondhand smoke exposure in non-smokers. So in 2008, the Alberta Tobacco Reduction Act prohibited smoking in public places and workplaces. And so we wanted to know whether this changed, not active smoking itself, that's to come, but secondhand smoke exposure. So actually protecting people who don't smoke. And we looked at their reported, self-reported secondhand smoke exposure before the legislation, so 2007 and earlier, and then after the legislation, which is 2009 and later. And actually, we found that both home and workplace secondhand smoke exposure were reduced by 50%. And we tried to control for as many factors as we had available to us. And we also created these maps, which also allow you to look at where you had the biggest reductions in secondhand smoke exposure and where there was less reductions. So we're in trying to collaborate with the tobacco reduction group to figure out how we can help support them in creating more targeted intervention strategies and identifying who might need a more a greater level of support. And finally, I wanted to highlight Karen Kopsiak, who is looking at determinants of cancer stage and diagnosis. So again, differences in individual factors, but also health system factors like access to screening, delays in diagnostics or access to specialists, potentially affect cancer survival and mortality. And current predictive models usually account for patient factors, but typically don't include information that actually may influence their likelihood for early detection and their level of risk. So they're not typically going to include lifestyle behaviors or other health system factors. So Karen's group is exploring patient and system factors associated with stage of cancer at diagnosis to understand the key important factors and to build prediction models. So these are going to be built from data from Alberta's Tomorrow project, and they're going to be validated in the BC Generations project, which is a really lovely use of the cohort as well. So that validation piece means that you have extra confidence that what you identified in one population also holds true in another population, and so will be more broadly generalizable to different situations and different people. I focused a lot on cancer, but I do want to highlight that the type of information that we collect is applicable across a broad range of chronic diseases. And so it's not just cancer. There's a lot of ongoing studies in a variety of topic areas, and we invite you to come and explore how it might support your research program. So what's next for CPTP? We were in recruitment for a very long time. We finished the baseline questionnaires or the enrollment in around 2015, 2016 across the cohorts. Again, Manitoba is recruiting now, but otherwise the other cohorts have closed recruitment. The most recent comprehensive follow-up health and lifestyle questionnaire was completed in 2018. And up next is a Presonomics project, which is generating genotype data in a subset of samples across the CPTP cohorts. And so in a few years, that data will also be available. BC and Ontario are in almost finished an occupational history questionnaire. Which is looking at, again, history of jobs held by individuals. Atlantic Path also has this data that was collected through their, at the time of enrollment. And Alberta is looking at doing a very comprehensive diet and physical activity data collection using multiple types of tools to try to capture a lot more detail about these behaviors and try and capture the complexity so that we can better support more holistic as well as more specific research investigations. And we were actively working with the other cohorts to see how we can support data collection in their regions as well. So just in case you're curious how to access the data, we do have a website. It'll be here and then on the last slide. You can go there and understand how the participants were recruited, what type of data we have available, more information about samples, how to access it and what the process will be, as well as the current projects that are using CPTP level data. You are also welcome to contact anyone of the CPTP leadership team, either through National Coordinating Center or within your specific region, if you just want regional cohort data or want to start the conversation there. And so I do want to take some time to thank the Tomorrow Project participants across the cohorts who have generously donated their time and information and parts of themselves. Really, it is their participation that makes this cohort so valuable, and their participation over time that is really going to help realize the potential of this platform. And we are incredibly appreciative of their support and involvement. And I also just want to take a quick minute to thank our sponsors, partners, and staff. We are very fortunate. Definitely at ATP, I want to thank all of our staff, including our longtime staff members. Their knowledge and experience has been absolutely integral to our ability to run the study effectively and efficiently. And we are also very fortunate to work with many great staff members across the CPTP cohorts who are very motivated, competent individuals who really push this forward every day. And I also want to thank our host institutions and our funders. A lot of these funders and host institutions have been with the regional cohorts and the national platform since the beginning and over time. And I think their ongoing support can't be undervalued, really. It really is thanks to them that we are able to continue this and that we have been able to build this platform and are now really launching off from here into the potential that this platform can realize. So thank you, and I'll take some questions. And again, if you want to access CPTP data, the web links are there.
Awesome. Thank you so much, Jennifer. Let's take just a short pause here. So for those who joined a few minutes into the webinar, allow me just to remind people to, if you'd like to ask a question, please click the Q&A button at the bottom of the Zoom window, and here you can type in your question. We have a few in the queue right now. If we can't get to all of them, please do reach out to us by email, and we'll be happy to connect with you. Our email is here, info@partnershipfortomorrow.ca. If you have suggestions and ideas for future webinar topics, I invite you to email us here as well. Finally, the slides from today's presentation will be available in both English and French on the CPTP website following the webinar. So if you've joined late or would like to reference back, that will certainly be an option. So I do see a few questions in the Q&A folder. I'll turn it back over to Jennifer now. And if you can just perhaps read the question and then share your answer with us. Thank you.
Sure. So this question is from Lavanya. How readily available is the CPTP data? I'm wondering whether it could be used to assess risk of other diseases. So this was said a little bit early in the presentation. I'm not sure if I totally answered it or not, but we have data available from participants through self-report. So on the different health and lifestyle questionnaires, we've asked them if they've been diagnosed with not only cancer, but a wide variety of conditions. So the self-report data is readily available. With the linkage, that right now has to happen within each of the regions. So if you're wanting to link to administrative health databases to pursue more, I guess, objectively recorded outcomes, you'd have to pursue that with the regional cohorts because administrative data generally cannot leave the provinces in which they are generated. But definitely the information in the platform can be used across a wide variety of chronic conditions. Okay, so the next question is, how many participants have longitudinal health and nutritional information available? So health information was captured again on the health and lifestyle questionnaires by self-report. I'm sort of excluding administrative health data right now. But we had 320 or around 300,000 participants if you take the 5 original cohorts who signed up initially and provided in the baseline questionnaires. And then the last follow-up questionnaire had a range of response rates across the platform. So the response rates were highest in BC and Atlantic. I think they were around 77 to 80% in those cohorts. So quite a lot of people with longitudinal health data. Sort of middle of the road, 65 to 70% for ATP, and then a little bit lower for Cardiovascular and Ontario Health Study. So in terms of self-report, it's a little bit different across the regions, but definitely still big numbers to work with. And then if you link in the administrative health data, that would expand your numbers. It really depends on what you're looking at. For nutritional information, the CPTP health and lifestyle questionnaires included fruit and vegetable intake as, I guess you could use them as indicators for diet quality if you're just wanting to try and account for diet somehow in your statistical models. Some of the cohorts do have more detailed nutritional information available on their participants. I think ATP is one of them, as well as Cardiovascular in Quebec and the Atlantic provinces. So all of us did some form of a food frequency questionnaire, which will give you a broader picture of nutritional information. So again, fruit and vegetable across the entire CPTP cohort, but more detailed nutritional information will differ by region. Okay, next question. How do you find out which participants have been diagnosed with cancer after they enrolled in CPTP? So we find this out in 2 different ways. One is through the health and lifestyle questionnaire, which we've asked them to self-report if they've been diagnosed with any cancers. And the second way is that we do link by participants' personal information to provincial cancer registries. So some regions will have this more readily available than others at the current time point, just depending on which stage they're at and in discussions with the cancer registries. But that's, so in Alberta, we have a gold standard Alberta Cancer Registry, and we link with them once a year to get those numbers. They are available on our website in terms of how many participants have been diagnosed with cancer. And I think BC also has this information. Atlantic Path has it for some of the provinces. Ontario has it through the Institute for Clinical and Evaluative Sciences, and then Cardiovascular has developed algorithms to figure out diagnosis of cancer through their administrative data linkage. So 2 different ways, self-report or through registry. Okay, next question. Diet is really hard to measure. How will you minimize measurement error in such a large cohort? So diet is very hard to measure. So previously we have used food frequency questionnaires, which do have a level of bias associated with them. They're really meant to capture overall dietary behaviors, not really so much for energy intake and specific nutrients, but the state of the literature right now really recommends using a combination of tools. So both 24-hour recalls, which are a lot more discreet. They're meant to, what did you eat yesterday, tends to be more reliable because you're looking at a daily intake, but you need multiple of them to really make estimates of somebody's typical intake. And then complement that with a food frequency questionnaire. So the food frequency questionnaire will help capture foods that you might consume every now and then, like fish, if you're living in a landlocked province like Alberta, that are still important for health, but that you might not capture with a 24-hour recall. So our approach, which is informed by the state of the literature and also was informed by an expert working group, is to assess diet using multiple 24-hour recalls over a year, and then also do a food frequency questionnaire. So we're hoping to get about 4 24-hour recalls and the food frequency questionnaire in as many people as possible so that you can maximize the strengths of the tools and try and minimize the error. And we are also plan to provide a lot of support to participants to be able to do that. The only way that we're able to even consider an approach like this, which will be, as far as I know, fairly state-of-the-art for large cohort studies where you can't really afford to do biomarkers. The only way we're allowed to do it is because of the existence of online tools that are specifically designed for self-administration, so designed to be quite user-friendly, and also designed for large data capture and use by large studies. So hopefully that answers your question. Next question, how could some of this information, such as the walkability data, be shared with policymakers for population impact? Great question. So I think this could be done in a few different ways, and I think this is really kind of a niche role that the cohorts could play. So I know for Gavin's study, he actually has knowledge users as part of the study team. So that's one way to build into your knowledge translation plans. But I think the cohorts also can play a unique role here in being that in between from the scientific research to policy and program makers. So at ATP, for example, we have specifically increased capacity on our team for knowledge translation. And found out that one of our new research assistants is actually very skilled in infographics, which is very handy. So we are focusing efforts on how to bridge that gap, how to be reaching out and helping to translate findings to make them useful to policymakers, and also to try and work with people who are involved sort of more on the ground in also designing some internal research projects. So I think we have a great role to play in helping to translate some of that information. But any ideas about how we can be more integrated with sort of the knowledge user community are definitely welcome. Next question, how often do you connect with the participants? Is there a way they can follow up with you to let you know about any health changes? Or if they move locations, would this change the data in any way? So great questions. So when we were recruiting, we didn't go out for follow-up questionnaires really because we were recruiting at the same time. And that was a very concentrated effort, not only because of the recruiting, but because we were also collecting biosamples and physical measurements at the same time. So once participant recruitment closed in 2015, we've decided at the national level that the most realistic time frame that we would want to go out to participants is approximately every 2 to 3 years. Given the scope and scale of the CPTP cohort, a lot of work goes into planning and administration, and also the rollout so that you don't overwhelm call center capacity, and so that we can make sure we're providing adequate support to participants when we are asking for their information. So hopefully from now on, participants can expect to hear from us for updated data collection every 2 to 3 years. But they are welcome at any time to contact us, particularly if they move and change contact information, which is not just address, but their emails as well. We communicate a lot more and increasingly with email, just because of the cost of paper mail and paper administration. So if you do change your contact information at any time, please do contact your regional cohort who stores all of that information. In terms of if they move locations to another cohort, would this change the data? I don't think it would necessarily change the data, but we haven't really looked at yet whether, moving participants into a different cohort, we really haven't done that. We do have participants, I'll just speak from the ATP experience because that's what I know. We do have participants that, are snowbirds, and so they spend part of the time away, or if they've moved to another province, we would still send them the questionnaires or any data collection in the same way. We typically update or ask for their address information when we do, so we know where they are living. So it wouldn't affect it for that, but it may affect it in terms of the data linkage. So if somebody moves from Alberta to BC, we only are able to link our participants with the Alberta Administrative Health Data and the Alberta Cancer Registry. So if somebody moves to BC or Ontario and gets diagnosed with cancer there, we won't see in our registry data that has happened. So some of just the realistic challenges that we have to work through collectively in terms of tracking and being certain about outcomes. Okay. Although fruit and vegetable intake is suggested for good health, how do you account for the chemicals sprayed on these items? Someone who does not eat many fruits and vegetables could potentially be of better health versus someone who eats highly chemically treated fruit and vegetable content in their diet. There's no way to sort organic versus chemical and GMO foods. Fruit and vegetable intake may not be a good option for consideration. So I can definitely understand the concern for GMO. There's always a lot of media coverage, and also how the fruits and vegetables come to the markets and things like that. I think you're always trying to take a balance of pros and cons. So I think the health impact of potentially highly chemically treated fruit and vegetable content is still being developed, and whether that does have an effect on health, because you also have to look at quantity, I guess I would say. So there is typically a dose response element to any kind of health risk. And so if you are consuming these chemicals, if they are present in the diet, if you're consuming them at a certain level, they may actually, in the grand scheme of things, not pose a health risk, versus the chemicals themselves potentially could have health effects, but you would have to consume so much of them in order to have an actual systemic effect. So I think that's a really interesting issue that really needs to be more explored, and it might be that some people are more susceptible to those effects than others. Again, things we just don't know. It could also mean that if you are concerned about fruits and vegetables that have been transported a long way, maybe you focus on sort of that local food movement, so that you can be more confident in where the food is coming from and that it has sort of lower preservation or processing because it's traveled a different distance. So happy to talk more about this offline, but it is definitely a very complicated issue. Okay, is there a specific application process in terms of forms and fees if graduate students wish to access CPTP data for smaller, potentially shorter term projects? So yes, the general application process is the same. The fee structure is different. So we invite you to visit the CPTP website for more information about the process itself. And then if you're interested, please do connect with the National Coordinating Center or the regional cohorts, and they can walk you through what the fee structure would look like and what the process would be. But definitely we are very interested in supporting trainees. So please, we are a very ready source of data. So please consider us for your projects. So have you or others at ATP considered studying participants who adhere to certain diets, so intermittent fasting, keto, and vegan, to explore how this impacts their health? Might be interesting as these diets are now fairly mainstream. So we have not done that yet. Again, it comes down to data availability. So you definitely can't do that from just asking about fruit and vegetable intake. Even with the food frequency questionnaire, you're really asking about, how often do you consume like a list of 140 to 150 different types of food items. So unless you have a specific question about whether somebody is intentionally trying to follow a vegan or keto diet, you're probably not going to be able to tease that out of the data. I think with our new approach, or the upcoming approach, where we do the 24-hour recalls and the food frequency questionnaire, we may be able to try and tease some of that out. I know in the food frequency questionnaire, there's at least a question on whether somebody is trying to be or intending to be vegetarian, and what level of vegetarianism. So we might be able to look at that. The intermittent fasting, I think you would have to do more of a targeted look at that, just because it's probably not going to be picked up in the way that we are collecting the data now. And so it's always a bit of a balancing act with the cohorts, because you want to try and support as many research topics and opportunities as possible, but realizing that you're not going to be able to be everything to everyone. But yes, there is definitely no shortage of dietary plans.
Jennifer, sorry, I'm sorry to jump in. I just want to acknowledge that we're a couple minutes past the hour,
Yes,
and I know there's another question or two here in the Q&A, and I'll make sure that we get this one addressed, and it will be shared on the website and on social and all of that good stuff. So I'm sorry, I just want to make sure that we're respectful of time. Jennifer, thank you so much for a wonderful webinar. We're thrilled with the context and the engagement that we've had so far. Thanks everyone for joining, participants, scientists, students, etc. The National Coordinating Center is looking to host our third webinar in the new year, and you'll all receive an email about it for more info. So I'd like to close here. Thanks very much to everyone. I hope you have a lovely afternoon.
Thank you.